Well, welcome everyone. I really appreciate everybody taking the time this morning to join us. We are a big supporter of Laude and Laude's mission in really showcasing injured workers, showcasing their experiences, really how we can come together as an industry to ensure that we're doing the right things by those that are catastrophically injured on the job. And so we have a great presentation for you today. We have an expert panel that I will introduce here in just a second. And really today's presentation is going to focus on one veteran's journey to recovery, that it really is never too late to recover. I think in workers' compensation, we can have cases where the individual is resistant to traditional medical care, meaning that, they go down the path that works for 85%, 90% of those injured on the job, but we have that subset of individuals that have injuries that for whatever reason, the care that is traditionally provided, that path of therapy, diagnostics, potential surgery, medications, that it just doesn't really work for them for whatever reason. And so today, we're going to talk a little bit about those things. And I want to go ahead and advance my slides so we can introduce our expert panel. So I will go ahead and go first. For those of you that don't know me, my name is Eddie Canavan, and I am the Chief Claims Advisor for Alta Claims Services. And the only thing that means is that when you work for your wife, you can give yourself a fancy title that doesn't mean anything. I've been in the casualty industry for almost 30 years. I have done everything from work in a file room to examine claims to manage offices. And before joining Alta, I was a practice leader for one of the world's largest third-party administrators. Sherman, would you like to go next?
Sure. My name is Sherman Gillums. I served in the United States Marine Corps for 12 years. And after suffering catastrophic injury and a period of rehabilitation, I joined the fight to ensure that veterans and their caregivers and families have a voice in Washington, D.C., along things like compensation, healthcare, dignity, and society. I've done that for the last 17 years now. I'm happy to be here.
Dr. Fisher?
Yeah, I'm Steve Fisher, and briefly, my background is that I'm an orthopedic trained hand surgeon, spent some years in practice. I have a PhD in neuroimmunology pathology, and I've since transitioned to a medical advisory role for a workers' compensation carrier, and also am a medical advisor on the medical advisory board for H-Wave, which is the capacity in which I'm acting today. So anything that I say will reflect on my clinical practice experience, my experiences in reviewing workers' comp claims, but do not necessarily reflect policies or opinions about the carrier that I work for or any other carrier.
Well, first, I just want to thank both of you for taking the time out of your very busy schedules to be here today, because I know your perspective is valuable and that our audience today will find it useful and insightful. So what are our objectives today? So first, we're going to talk a little bit about Wounded Warriors. I'm going to go over some stats regarding Wounded Warriors, regarding our nation's soldiers and what they're currently going through. Dr. Fisher is going to spend a little time talking about the definition of insanity and what is that? That's doing the same thing over and over again and expecting a different outcome. I think sometimes in casualty, especially in workers' compensation, we can get stuck in that rut, and it's really because of the foundation of workers' compensation that we use evidence-based guidelines. We have, again, a path, we have laws and statutes and regulations that we have to abide by and follow. But sometimes when we get stuck in that rut, in a certain subset of cases, we're not really able to get the injured worker to that finish line and that result that they need. And so Dr. Fisher is going to spend a little bit of time talking about that. Mr. Gillums is going to give us his perspective, his story, his journey from being catastrophically injured to now being a senior leader at AMVETS. We're also going to talk a little bit about our nation's mental health and how that's being exacerbated by our current pandemic. We're also going to talk a little bit about our nation's pain crisis. We are so focused on COVID-19, and rightfully so, but I think what we're forgetting is that we still have a pain crisis in our country. We have 100 million Americans, by some studies, that report that they have ongoing chronic pain, and they really now are challenged with proper access to care through this very unprecedented time. So are there treatment alternatives? Are there things that we could be doing differently given the current atmosphere that we're in, the current environment, landscape? And are there alternatives that are effective? And so Dr. Fisher, as well as Mr. Gillums, will spend a little time talking about that as well. And then we'll finish up with some closing thoughts and answer any questions that you all might have. So let's talk a little bit about Wounded Warriors and some of the stats around what our current Wounded Warriors are dealing with. So we have currently, we have about 6.4% that are currently on active duty, and those are on active duty are deployed nearly 3 times on average, with 93.4% of soldiers deployed since 9/11. About a good majority of soldiers report post-traumatic stress disorder. They have problems sleeping. They battle neck, shoulder, back pain. 70% report that they suffer from depression. And Mr. Gillums is going to talk a little bit later on about the care stigma that, we have warriors that think, look, I'm a warrior. I'm a strong person. I'm here to protect my nation and to fight for my country. And, maybe going and securing care, especially mental health care, maybe could be looked at as a weakness. And, so by not getting that care at the right time, then they might be jeopardizing their future, jeopardizing their ability to get a career outside of the military. And again, a lot of them are just concerned with the perception that brings. Work barriers. So Wounded Warriors, 33% report profound mental health issues that can really block them from being able to secure a good job, a good paying job to sustain themselves and their families. And 20% actually report just not being physically capable to work. The demographic for Wounded Warriors, 42 is the mean age. 65% are married, and 37% have completed a higher education, with 54% enrolled from the military from mostly southern states. So it's interesting when you start looking at the very stats and what that means. And so next, on our next slide, we want Dr. Fisher to spend a little time talking about really the current shape of how we treat injured people. That, again, it's that definition of insanity that we sometimes get in that rut and do things over and over again. Dr. Fisher, can you explain how physicians can possibly break that cycle, especially when the patient appears to be resistant to traditional medical care? Maybe traditional medical care isn't the right word, it's just resistant to medical care. And also, I know Mr. Gillums might have some thoughts here as well. How do we measure the effectiveness of treatment of pain? Do we measure it in an effective way, or is it really more subjective that could then lead to inappropriate care?
Sure. So I think you already brought up that most injuries follow the usual treatment course of recognized treatments and the usual expected recovery course. And then there's a subset of people who really, we refer to it sometimes in our company as unexpected medical outcomes, which is somebody that it could be either a complication of care or something else, but also could simply be they're taking too long to get better. It's not resolving according to the usual course. And the time course for these things can be very protracted. And so sometimes what happens is you see this sort of stepwise progression, and somebody needs to actually go back and re-review the whole thing medically to make sure that the initial diagnosis was correct in the first place. Or maybe there was more than one diagnosis, and it makes it a little more complicated if a secondary diagnosis wasn't related to the work injury, but maybe impacting the person's recovery. So when somebody is not recovering as expected, we really rely heavily on independent medical evaluations, but you have to ask the right questions. and also review the right records, review the right history to try to figure out at that point in time now what is going on and what is impacting that person's recovery. And I think that the workers' comp sector, it's getting spoken about much more frequently now. There are factors, certainly pre-existing anxiety and depression or substance use or other types of issues that may not have really been an issue for the person going to work every day and doing their job, but now become they've had their surgery, their procedure, or maybe not, but their injury should have resolved by now and isn't. And these factors may now be significantly impacting that recovery. And identifying those is really key to understanding what do you do to get out of the rut. So I don't know if that sort of addresses what you're getting at. I mean, in terms of getting out of the rut, identifying those factors first is key. Then you explore what's available to try to address those factors.
So I think that myself being in the workers' compensation industry for quite a while, when I was an examiner, I think that my number one concern was if I look at this individual in a holistic way, then I end up paying for care that's not part of my claim. And I think for a long time, to your point, Dr. Fisher, that it was around mental health, that we would have injured workers that we would not identify mental health issues from the get-go, and we would end up having them bleed into the claim later on. We would have somebody that ends up with a back issue that goes on for a year, 2 years, they can't work. They're concerned about how they're going to take care of themselves and their families. They're concerned about their future. And then we end up getting a claim from an attorney that now they are depressed. And to your point, are there, 4 or 5 things that when somebody claims an injury, not everybody, this again, we're talking about a subset. Workers' compensation really is a very effective mechanism to deliver benefits needed to get people better. Most people do get better. A large majority of injured workers get better, get back to work, claim is closed. But then again, we have that subset of injured workers that don't. And to your point, Dr. Fisher, how do we identify that subset? How do we then ask the right questions from the get-go where the carrier, the employer, the examiner, the stakeholders are comfortable that we're not necessarily saying that somebody falling off of a ladder is causing depression, anxiety. What we're saying is that a large percentage of our nation currently, and we're going to talk about this a little bit later, is suffering from these things. And if we don't think about it, and if we don't address it, then the claim that could cost the carrier or the employer $35,000 is now going to cost them $250,000. So Dr. Fisher, do you have any thoughts, further thoughts around how, our industry, examiners, physicians, employers can work together in trying to identify this subset in a meaningful way and ask, what questions should they be asking to really look at them from a more holistic perspective?
Well, I think that, the holy grail would be to identify somebody, maybe before they ever even had a surgery, but soon after an injury, and say, okay, this person is at much higher risk for delayed recovery, getting into the rut, opioid misuse or overuse or prescription medication issues, and trying to take that head on. Now, carriers, understandably, as you pointed out, you really don't want to end up accepting a lifelong diagnosis and treatment for, say, depression or anxiety. And I think one of the things that the industry has pointed out is people can have anxiety and depression surrounding an injury and recovery. That does not mean that now that is a permanent condition for them. And so I think that people have to be very careful about labeling people with things and also assigning diagnoses and other things, especially when it comes to mental health diagnoses. Because in the setting of an injury where somebody was working before, then these things theoretically should be surmountable because it was before. So the question is how to get them out of the rut, and really ideally, how do you figure out who they are very early on? And I think you see more and more, and granted, as a carrier, we're not talking to patients. We're only seeing what people write down. So the version we get is only as good as what gets written down. EMRs have been helpful in some ways, but because of the templating and other things, we lose out on some information in some other areas. But questions like history of substance abuse and mental health issues and other things now are making their ways into EMRs and getting asked more routinely, and that's good to know. Something that our company does is we try as much as we can to use opioid risk assessment questionnaires because they're very highly predictive for somebody that may get into trouble with this, so that we can maybe provide extra support and at least be aware of it before they head into the rut, because it really looks like it's much easier to try to head that off before these things really evolve and are really set. And it is an issue that you have to be careful that the carriers don't necessarily want to just send everybody for a mental health evaluation either. But something that I think we're seeing increased use of is cognitive behavioral therapy. There have been studies published on it, even people non-workers comp who will have CBT before a surgery, and it's been helpful to them. So does everybody need that? No, I can't imagine they do. But trying to figure out who does. And then also from a provider standpoint, I mean, when I was in practice, and I could do a carpal tunnel, I did it the same way every time on everybody, and it took maybe 7 to 10 minutes, and nothing was different. And some people recovered like it was nothing, and some people never recovered. And you scratch your head and go, what could be going on here? But I do think especially as somebody doing procedures, you sort of get a sense when somebody is falling off the recovery curve, the things aren't progressing. Now, there may be a tendency, in orthopedics, you can say, well, here's the x-ray and the bone. Hardware looks good, bone is healed. So what's the problem here? And there's clearly a problem because they're not doing as well as the other 6 people with the same x-ray and same thing. So, and the tendency is to offload those people in the direction of pain management. But I think the pain management community is doing a better job also of identifying maybe these hidden factors that a claims adjuster or somebody else may not be aware of that are impacting that person's recovery, ability to recover. And that might allow the carrier to open up some options and make available things to help the person over the hump.
And I do think that in some instances we might miss opportunities for the employer, for the examiner, and the carrier to really have a meaningful dialogue and partnership with the physician. With networks in place and other necessary managed care techniques. The injured worker sustains the injury, they're referred to the network physician. The network physician evaluates that individual, they follow guidelines, they recommend treatment that they feel is evidence-based and necessary. But maybe the examiner had a conversation with that individual and they're exhibiting fear, that they're fearful that they're going to lose their job because of the injury. They're fearful as to how they're going to sustain themselves. And I think that when the injured worker exhibits fear during that initial conversation, that's, I think, something that absolutely needs to be conveyed to the physician, because in my experience, when you have an injured worker that is in that state of mind, the recovery is not always good. And also in those cases, with that subset, that small individual subset of individuals, they also, to your point, Dr. Fisher, they don't recover from the carpal tunnel surgery, and then they end up with complex regional pain syndrome. And then we are dealing with a psychiatric component of the injury that, to your point, we could have addressed from the get-go, from being able to really talk to each other in a meaningful way, in a way that I don't think we're talking to each other today. And I think that really segues nicely into our final point here on our slide, is that, and Mr. Gillums, I know you have some thoughts on this, is really how do we measure the effectiveness of treatment relative to pain? We have, again, certain studies show that we have 100 million Americans reporting that they have experienced chronic pain. There are university studies, I think by Stanford, that show that 80% of our population report that at some point in their life, they had to deal with ongoing chronic pain. For years, we felt that the right solution to that was a combination of pharmaceutical and therapy treatments, and that we've learned that, the pharmaceutical component is not always effective. It can create hyperalgesia, especially for somebody that might have anxiety, depression, perhaps they could catastrophize things. And so, Dr. Fisher, as well as Mr. Gillums, I would love your opinions on how we're currently measuring the effectiveness of treatment relative to pain, and are we missing some opportunities?
I'd like to just point out real quickly, I mean, pain, obviously a very subjective thing. And when a patient comes to you and says they're in pain, that can mean a lot of different things, a lot of different ways. And they don't necessarily just, especially the people who catastrophize or are very anxious, don't show up and say, I'm catastrophizing and I'm very anxious. They're very focused and catastrophizing about their injury, their body part, other things, but they don't necessarily articulate it. And that's where I think, at least on paper, we see instances where it appears that really the major issue is pain, is anxiety, and possibly some depression that's getting treated with opioid pain medications. And I think we all know that's not the best treatment for anxiety or catastrophizing. I'll let Chief Officer Gillums jump in.
Sure. You hear the term pain is subjective, and it is, but I think that understates the point. One of the things I learned watching human beings of all walks, races, ages, genders suffer spinal cord injury is that you get the individual as they are. You get their life experience, you get all the things that happen to them. They're a record of experiences, and they come to what I think medicine tries to do sometimes is to a baseline where everybody's, when they're asked about that 1 through 10, the 1 being the smiley face, the 10 being the mean face, where you fall on that. And that's going to be different because interpretations are different. And we hear a lot about evidence-based medicine, and I think that's the place you start. But we know that even in evidence-based medicine, who was tested? You have a lot more women in the military than we did before. And a lot of what we've learned about how to treat veterans hasn't been adequately explored when it's a different gender. One of the things that, and you talked about Wounded Warriors, Eddie, when you listed the profile, one of the things I wanted to point out is the profile is a lot different than it was even 30 years ago. We have a lot more National Guardsmen. We have a lot more women, a lot more older veterans than the typical that would join at a younger age. And so you've got a broader cross-section of society who now comprises the military. And that means that when the injuries happen and when they suffer conditions, the medicine has to catch up. And I don't think it has yet. I think we're still finding too many gaps where we expect them to be at the sort of baseline of who they were before the injury, and then we go from there when that's not the case. Some of these people that went to combat were also sexual assault victims before they went to combat. And so they suffered the injury, they suffer any subsequent conditions. It complicates the way that they're treated. And we're always advising doctors to not just talk to the veterans, but talk to people who live with those veterans, the caregivers, who will tell you everything. The veterans will leave out things like how much they drink and some of the other aspects of treatment that rely on their being a historian when you really can't get to the truth unless you look at the veteran as a whole. Who's around that person? Who would know more? Who should be in the room when you talk to those veterans? And so, and I know we're talking about workers here, but I think there's a lot of parallels when we understand that people are more complicated than their circumstances often allow them to be perceived, and medicine has to catch up to that.
I think that's an excellent point, Mr. Gillums. And I think that's you really touched nicely on, some of the things that Dr. Fisher pointed out is that, yeah, you do have this individual that has a whole history of issues. We take that individual, we put them through a treatment plan that may not necessarily be tailored for them. But again, it's worked for 85% of people, but for whatever reason, it's not working for them. And so, Mr. Gillums, I would like to segue into really the whole point of our presentation today, and that is really to hear your story, one veteran's journey to recovery. First, I want to make sure I thank you for your service. It's so important that we make sure to thank our veterans and our wounded warriors and our the men and women of our armed forces that are making tremendous sacrifices every day to protect us. And so I am very thankful that you did that. And we want to hear your story of really being catastrophically injured, and then your journey in overcoming so much to now be a senior leader within AMVETS.
Thank you, Eddie. One of the things we do at AMVETS is we look at the veteran not just as a whole person, as a holistic problem we have to address, but we also look at the person's experience through a journey map. And what I mean by that is, before you raise your right hand and take the oath, you were an individual who brought what you brought in to the military. And while the military and the VA presume 100% soundness, meaning you have to be basically 100% employable, is what that means. No flaws, no defects. That's not true. And I was a drill instructor for 3 years, and I saw these young men when we got them, and some of the bodily function issues and some of the the mental limitations and all those things that become exacerbated by military service. But I came in at 17 years old back in 1990, pretty healthy. I think I was a healthy 17-year-old kid when I got to boot camp. Mentally, I think a lot of folks are not as developed as they eventually will be as adults. So you're talking about people who are still in their formative years and being formed in terms of how they cope with hardship, and that has implications later, especially when you send them into those situations very early in their career. And I see a lot of downside to sending young men and women in harm's way very early. They have to, that's their job, but there is a downside to it because they're going to live a long time with the consequences of that. And we have to be ready to deal with that. In my case, I managed to serve 12 years. And after 9/11 happened and the towers fell, I was assigned to 1st Marine Division. I never made it to deployment because as I was going through the base at one point, I was run off the road by a semi-truck that swerved to miss another vehicle. I don't know if he had crossed a line or something, and by evading that collision, I flipped my car 3 times, and I was upside down when I was pulled out. And at that point, my vertebrae snapped, and that was it. It was just that quick. I was airlifted, taken to surgery at a Scripps Memorial Hospital in San Diego. In a coma for 3 days, woke up, and my life was different. Everything was different. Now, I wouldn't have known this back then, but looking back now, my life up to that point mattered. Everything I'd been through mattered. Every injury I'd suffered, I think I had some broken ribs and a collarbone injury at one point. All that played into my rehabilitation. And Dr. Fisher, you talked about why certain things don't work. Well, I went into that injury already have had a compromised shoulder. So structurally, I couldn't rehabilitate as effectively as I needed to. And the pain medicine didn't work because neurological pain is something different. It's something far different than mechanical pain. So I was already feeling the consequences of all the military service up to that point, all the jumping out of planes and all the humps and boots and all the things, just things like sleeplessness, the insomnia, which is an accepted aspect of military culture. It came back to haunt me because it affected my ability to mentally cope with what I was facing at that point, which was an abrupt change in who I was, both physically and mentally. But I did recover. I took about 2 years to do inpatient and then outpatient rehabilitation. And I got to go to the bedsides of a lot of people who were injured in combat, were shot, were blown up. We did a poor job, and when I say we, I'm talking about the VA and the government, of identifying traumatic brain injury as an aspect of care. When we talk about the holistic individual, that was a big missed opportunity for many men and women who didn't even get screened for concussive blast syndrome. And so their rehabilitation was impeded by their inability to follow instructions and to conduct themselves in a way that you'd expect somebody to when they don't have a brain injury. And because they didn't train their personnel to see the signs and to understand that the suggestive language and some of the conduct that's indicative that there's something not right wasn't just misconduct. It was this individual needing to be better understood for what he or she went through. And this was especially pronounced in women because you don't normally associate women with combat, but they were in combat. They were getting shot. They were losing limbs just like the men. It was an asymmetrical battlefield. And so because it was asymmetrical, anybody, you could have been a mail clerk with concussive blast syndrome. And I think that when we had, and I'll relate it to where, they go out into the workforce to get out of the military like I did, eventually in 2002, you join the workforce, you bring that with you into the workforce. So if that doctor who's looking at a subsequent injury in the workplace under regards what service and the hardship and rigors of military service have done, then you're going to miss a big piece of why there will be problems. And I want to point out something else that's very important. Most military service isn't combat. Most of it is not. Very few, proportionately speaking, go to combat. What happens is the lifestyle itself is what diminishes you over time, and you accelerate in age about 10 years the longer you stay in the military. So we're talking about survivors of military sexual trauma. We're talking about folks who got inoculations and different shots that affect their neurological systems, which may impact response to treatment. We just had the Gulf War anniversary here not too long ago, and we were talking about some of the drugs they were given, malaria pills, the exposure to there was a coating they will put on Jeeps to make the sand stick less, so everything wouldn't have sand coating on it. They were breathing that stuff in. And the culmination of all those things is a part of their journey. And so you get the individual as they are. There's no baseline. The baseline looks like this. It goes all over the place because everybody's different. And so when I talk to doctors about evidence-based practices, I understand that's the starting point. But in many cases, they run out of options at that after they've exhausted what's considered the traditional paths that don't work. Or when they're scratching their heads trying to figure out why it doesn't work. Well, because evidence-based therapy doesn't mean the sample size was 1 million people. It means they were satisfied that enough of that sample gave them enough information to move forward. But even with COVID-19 and the vaccinations, are we going to have enough women and people of different races involved in those clinical trials? And if we don't, then we should expect to see limits on what those evidence-based therapies can do and perhaps expand what evidence means in terms of new frontiers in medicine. So in my case, I went through a lot of ups and downs with respect to how I managed my spinal cord injury in college, in the workplace. Everybody's different. I know people with the exact same level of injury as I have, and their journey is much different. Their spasticity hits them differently, and their neurological pain. And part of that is because we live in different parts of the country. If you've got bad joints and you live in the South, you probably have an easier time than somebody who has to deal with the four seasons. So a lot of those aspects of the journey are important to consider. And doctors can't know them all. They won't get everything. And so there's that efficiency we hope to see in EMRs where we'll capture more information. I know the VA has a system called My Healthy Vet where we can upload information into our records. So we provide the gap fillers where we're talking about things like pain and how often we have it, what triggers it, who sees it. And maybe these other historians can be a part of that process as well. And then finally, I was happy to see through our work on the caregiver committee in the VA to finally get a section that discusses the caregiver and who the caregiver is, what the caregiver sees, what they remember or recall about certain situations. So I'm not sure if workers' compensation doctors even talk to family members or consider lay statements and things that aren't clinical in nature, but that's a big piece of who we are when we come into these situations.
I do think that that can be overlooked from time to time, and really involving the family, especially with the people who are catastrophically injured.
Mhm.
I do think that that is something that we should think about as an industry, is how we do engage others. Because to Dr. Fisher's point, to your point, that those family members might be able to shed some light on that individual. To your point, Mr. Gillums, there are prior experiences that could um, uh, preclude them from being able to recover in the same manner as others. And then also your point to evidence-based medicine, and should we be willing to do things that may not be necessarily outlined in black and white in evidence-based medicine? That's something that I think our industry has always been a little bit fearful of. But before we move on, guys, we need to conduct a quick poll. So I believe WorkCompCentral is going to get on the line and guide us through that. All right.
Yep, so it's on the screen. So go ahead and everybody take a look at your screen now. This is how we can certify those CEUs. So everybody, if you're going to be claiming CEUs, we got to show that you are attentive and listening. So it's on your screen now. So it's how long have you been in workers' comp? Just as simple as that. And we'll give you about 10 more seconds and then we're going to close it. So make sure you answer the poll question in 4, 3, 2, 1.
All right. So let me go ahead and go back to my screen, because I think for whatever reason my screen went away. So let's do that. Perfect. All right. And so I think both Dr. Fisher and Mr. Gillums, you both pointed out the importance of really considering mental health when we are looking at how an injured worker's treatment path should be forged, should be planned and put in place. And I do feel that mental health, it can be a profound issue when trying to recover from a catastrophic injury, both pre-existing mental health issues, but also mental health issues that are created by the injury itself when one is catastrophically injured, like you, Mr. Gillums. And when we look at the stats, they're a bit concerning. We seem to have a majority of people that are stating that they're either anxious or they're depressed. The stats show that 1 in 5 adults state that they have experienced a mental illness at some point in their life, and 1 in 25 state that they experienced a serious mental issue. 50% of chronic issues start when people are teenagers at age 14, and 75% start at age 24. Here we show that 18% suffer from anxiety disorders, 8% report experiencing depression, 1% battle psychotic disorders, 7% experience post-traumatic stress disorder. And what I find very interesting but also concerning about post-traumatic stress disorder is that, Mr. Gillums, you look at somebody that has been in combat, and I think it's pretty much guaranteed that they're going to have some sort of post-traumatic stress disorder because of what they saw or what they experienced. But as Dr. Fisher pointed out, the individual can also really guide as to whether or not they end up with PTSD for other things that have happened in their lives. It could be abuse. It could be a whole myriad of things where they end up suffering from PTSD and not even be aware of it. And then from a warrior's perspective, when you juxtapose the stats with our nation versus our warriors, and Mr. Gillums, I know that you might have some thoughts here as well, is that, it shows that 1/3 have had suicidal ideations, that physical injury led to mental illness. So I think we talked about, that catastrophic injury leading into a mental illness, and 70% report being exposed to toxic exposures. Mr. Gillums, you want to add anything to that? I know that this is a subject that is close to you.
Yeah, I want to push back on one point you made. There's no guarantee that an individual will get post-traumatic stress disorder just because he or she is exposed to trauma. Everybody's different. Some folks go out there and do quite well. That's why they can go to combat early in their careers and function and do 20 years and even 30 years and get out and be just fine. I know plenty of people who don't suffer post-traumatic stress disorder. It's the way the brain kind of records trauma and deals with it when triggered by certain things. That doesn't happen to everybody. So I want to make that point clear. I do want to say that with the suicide problem, I think there are levels to it. You know, there's hardship and the inability to cope with it. There's thoughts of despair when you have to get out and you're not connected to your tribe anymore, which is the military. And then I've seen those who take it a notch up and actually attempt to die or have has realized the attempt and died. And we can't blur the lines too much because everybody's not at that point. A lot of people simply want help and can't find the help they need. And for example, somebody with a spinal cord injury that's ever had to experience a condition called autonomic dysreflexia, it's like a mini stroke that tells you there's a noxious stimuli somewhere in your body. Anything from a bent catheter to a impacted toenail or something. It's miserable. It's a miserable condition, and you want the pain to end. You don't want your life to end. You want the pain to end, and that's a whole different thing than someone looks to his or her life. It's not worth living. That's an entirely different thing. So I do want to make sure that we don't go too far with not you yourself, but we don't stigmatize as a population veterans because they're all still different. I will say this time we're in, it's going to fundamentally change how we look at what's normal. I mean, there was a time when if you were constantly putting sanitizer on your hands or wearing a mask when you didn't really need it or getting angry and all the things you see that have become normal, I think we're slowly slipping into a society that's mentally ill, and we've accepted that that's normal. And so when you take those same people who were already on March 7th, 8th, or whenever that point was when we stepped off the coronavirus cliff here, they were already in trouble. They were already in a position where they needed care. And most of them were told, we can't honor your appointment because we have to shut the hospitals down and things like that. So my fear was that we were going to see a cumulative effect on top of what already existed. And now we have to deal with not only those who were in despair, we also have to deal with those who are put in despair and the potential contagion effect that it will have on the kids, on people in the home that are situated with that individual for prolonged periods. And you're going to have kids now who are growing up in this time, seeing their mom and dad or whoever else is in the house have these issues, and how that affects them is just an extension of what's going on in our country and the impact of mental health. It doesn't just sit with the individual. It normally has that cumulative effect on the family.
Right. And I think that actually segues nicely into our next slide, Mr. Gillums and Dr. Fisher, is that, we've talked a little bit about, our pain crisis in our country. And Mr. Gillums, you just articulated very well how the recent events have presented some challenges to accessing care. And how is this really impacting those that feel a need for invasive care? So you have the elective surgeries, you have the hip replacements, you have the knee replacements. And so how are they challenged? How are veterans challenged when active and discharged in addressing and treating chronic pain? So, is the pandemic adding a layer of complexity to this? And, are there things that we can do perhaps differently to try to help people through this very difficult, unprecedented time that are challenged by chronic pain?
Just to give you a little example of why it's different for some veterans, a lot of us remember when we were taught how to don a gas mask, and it was, you just sort of get that your heart starts fluttering when you imagine for a second that if you don't get this seal right, and if everything isn't right, what can happen? Well, you're going to have these toxins get in your lungs, and you'll start to cough up blood. They put that image in your head, So imagine being that individual who went through maybe the Persian Gulf War or even the more recent conflicts, and you're sitting at home and they're saying, you hear, back in March, don your mask, or this virus, which is shaped like this little ball with spikes, is going to get in your lungs and eat away. You revisit what it meant. How do you don an N95 mask? How do you, create a seal? Is it tight enough? And so because you're pushed back into that fear, you revisit what it felt like to be in those moments, and then you couple that with the social unrest and the violence and the sort of mob effect that has, and it gets you thinking about what it was like being in Fallujah or places where this was a way of life, and you thought you were going to come home and be free from that for the rest of your life, and it's here, and you can't escape it. And I think that's where a lot of veterans lose hope, because when you were in the military, you had a weapon, you had your comrades, you had a battle order. It was much different. You were in control, even when you were subject to the environment. Here, your family's at risk, and you can't protect them. You've got a lot of things happening on television that pump these constant images of fear and trauma into your mind. Not to mention YouTube and all the other places where you can go get content, and you create a ticking time bomb in some of these people, because on top of that, they can't go to an appointment. They can do telemedicine, but for a lot of them, that's not adequate. And it's not, in the case of those with concussive blasts on top of depression and post-traumatic stress, it's not just a matter of treating the mental or the psychological aspects. In some cases, medicine just for post-traumatic stress is not ideal for somebody with organic brain changes. And that has to be a factor. And so when you cut off access to care, create an inescapable situation, and add that on top of unresolved mental health issues, it's no wonder you have veterans at the point where the only escape that makes sense for them is to escape for good. And we want to stop that. And by the way, it's not just veterans. We see a lot of teenage kids going through this, caregivers who could get a break by taking their kid to school, right? Drop the kid off at school, come home, maybe do some caregiving. Well, now their kids are at home. There's no escape. There's no break, and that wears on you after a while when there doesn't seem like an end is near.
So no, I mean, Mr. Gomes, you make so many great points. I mean, it's just, it is just such an unprecedented, just such a different time. Dr. Fisher, we'll love your perspective here on, our pain crisis, how you're able to practice medicine during this unprecedented time, and really, are there alternatives? And I'll throw this out to Mr. Gilms as well, but on our next slide, are there treatment alternatives available for physicians really during this time where some people don't feel safe leaving their home? They might have underlying health conditions, and so they're not getting the hip replacement. They're not getting the treatment that they were accustomed to getting to help them get through these issues and that pain. And so, Dr. Fisher, I love, well, as well as Mr. Gillis, but I love your perspective on really how you've practiced medicine during this time, and what do you see as some plausible alternatives to helping people that are in chronic pain, but they can't necessarily get the care because they don't feel safe getting it?
Well, first of all, just to be clear, I'm not practicing at the moment. I'm full-time with the insurance carrier. But when this whole COVID situation erupted, it significantly impacted the ability of our patients of the company and everybody. My wife is a physician. It significantly impacted people's, number one, ability to get care, but also people who may really needed to get maybe even emergent care were afraid to go get that, because of the exposure risks to them. And to some degree that continues now, although for better or for worse, because I think there's definitely pluses and minuses, we've really seen telemedicine emerge much more strongly in these last 6 months. It was getting some traction anyway, but now it is here, and it's firmly here. And that may offer some opportunity to try to at least interact with some of these folks. It may not be the same, it may not be the same quality experience as somebody going and seeing a doctor. There are some services that, access to surgery, which is improving now, and procedures is improving now. Physical therapy is improving, although they're much more limited in terms of the number of people that they can have in their space at any one time. So it is delaying care. There are patients who aren't comfortable going, say, for an independent medical evaluation or a treatment visit or something else, because they're worried about going out to medical environments and getting exposed. So we're even seeing some telemedicine independent medical evaluations, which have their limitations, but are probably better than nothing in order to at least try to provide something. But yeah, certainly, I mean, people more so before, I think it appears to be improving, at least in our area. I think it's different in different areas across the country, but their access to pain management procedures if they need them, or other things. So then the question is, what do we do with that? And are there other things out there that maybe we should be trying? And I think Mr. Chief Officer Gillums brings up a good point about some of the limitations of evidence-based medicine. I mean, when you're talking about huge numbers as a payer, you have to come up with some concept of what you're going to do with what. But there are certain treatments that there will never be huge numbers enough to have a statistically significant randomized study. So I think more maybe so, certainly in the Maryland workers' comp system, because every state is different, there is a little bit more latitude to maybe call it, there may be, call it a lack of evidence for a certain treatment or a lack of support, but there may be certain providers that have a good experience with it and therefore might be something worth trying. But there are other workers' compensation systems where deviating from sort of the written guidelines is very problematic. So it's variable in the workers' comp system, but certainly there's concern about people accessing what they need, and maybe what could the alternatives be?
Right, and a friend of mine, a colleague, sent me recently a study that shows that opioid deaths are actually on the rise during the pandemic. And again, it's just, is that because some individuals are still sheltered in place because of their fear of contracting and succumbing to COVID? And, if you have a person that's really battling, that ongoing chronic pain at home, what would be a good recommendation for them? What sort of things could they do? And I know, Dr. Fisher, you noted some of these things. Maybe it's cognitive behavioral therapy, because you could absolutely do that via telemedicine. But would there be other things that these individuals could do to try to help them until they can get the care that they need?
Well, and I'd like to maybe defer to Chief Officer Gillums on this, but I've had people say to me before, you can go do CBT and other things, but you're not going to think your way out of every pain situation because it's simply painful. And so, yeah, there may be strategies and mental strategies, and it's probably more so with acute injuries, but when you're talking about more chronic problems, that doesn't necessarily, at least on its own, you take somebody that is simply cannot deal with what they're experiencing and say, here, meditate your way out of it or something, may not be realistic either.
I think a lot of the benefits of my experience involve, again, seeing a lot of people across a diverse population, probably handle the injury What were the differences? What were the similarities? And one of the things that the Department of Veterans Affairs got right with spinal cord injury specifically is from the beginning, they want to rehab you in a way that teaches you how to not need doctors and hospitals. So you don't need people. You don't need, and once you develop this bond with these drugs and certain therapies and things that um, they don't change your perspective or how you cope with pain, they directly address it in a way that's temporary. When really what you need is how you perceive the pain. It's your pain is there, but how you perceive it. And I think when folks take a pill and that's the only thing in their mind that makes them feel better, that's almost the beginning of an end for a lot of people who won't be able to get into these doctors. I mean, there's only but so much you can take. It's like alcohol. There's only but so much you can drink before you can't get any drunker. And then you go to something more powerful and you begin to self-medicate because now the internet gives us all these options and all these, WebMDs and all the things that we can use to self-medicate. So it's like handing somebody, a loaded weapon without teaching them how to use it when you can't access care, but you can access opioids. So it doesn't surprise me that that's probably true, that it's happening because a lot more people, and I feel for the doctors because they have to do something. They have to do what seems right, what the science says was right, and they're going to be wrong in some cases. But if you deviate too much or if you go too far in one direction, you can do more harm than good. So it's a real conundrum for our healthcare workers and our doctors. And I really, you commend veterans, I commend healthcare workers. Anybody who chose that profession ought to be commended for that work because relief from pain is not easy. And then when you lay on top of it everything we're going through now and how complicated it is, and the fact that we've got an opioid crisis, it wasn't as if that was a new thing. That was here for a while. It was going to get worse. And the question I have for policymakers on Congress and in these hospitals is how did you, what kind of preemptory ideas did you have? Did you put things in place knowing that you were going to have to cancel all these appointments? How are you going to account for all the need there? We're going to sit in place and have to wait until this resolves a bit. But what are we doing? Are we thinking ahead far enough so that when this thing finally does open up and people can go back to hospitals, they're going to be in 10 times worse shape than they were back in March when they were already in need of care. And I'm not sure that we're doing that. I think we're still firefighting instead of preventing fires in our healthcare systems because of things like the unexpected propagation of this virus and where it's hitting and how it's impacting staff and things like that. So it's almost a hellish situation that doctors and nurses and all the others find themselves in. But we better start thinking about it and think about how it has changed the healthcare landscape, because if this happens again, there's no excuses. We saw it. Yeah. And we're starting to get to that point where we can't make too many excuses anymore. We have to do something.
Well, we're coming up on our end time here. I think we have 1 moment left. I wanted to ask our WorkCompCentral team if there were any questions in the chat feature or if we're fielding questions.
Hi, yes. Well, yes. So we do have some questions, but first and foremost, I would like to thank Mr. Gillums for your service. I think that me and the audience all share that sentiment. That's been the biggest thing that's been coming across. So thank you.
You're welcome.
But let's go ahead. So we do have some questions. And the first one is, have you seen a positive increase of care for our military and veterans?
I see the positive expansion of options. One of the ways I came into H-Wave myself, in fact, my wife was also a veteran, was prescribed an H-Wave before I even knew what it was. So she was already mitigating her pain using an H-Wave device. I adopted that as my, number one option because it gives me so many choices in how I can address pain throughout my body. But it's things like that. It's making care accessible. So we can go see a doctor at VA expense, provided it's a vetted doctor. That's been a positive development. I do think there's a cultural competency gap that many of those healthcare professionals need to close, because they're going to start treating veterans as if they're ordinary patients, and they're not, especially the women. They're different from women who are not veterans in a lot of ways. So I do think it's gotten better, though. I think the need has gone up, though, and we need to see the system keep pace with it.
Thank you. And the next one is, there's a lot of crossover with injured veterans and injured workers. Is there collaboration for best practices for approaches to SDOH and RTW?
I don't know what those mean, so I'm gonna RTH and RTW, STOH.
SDOH, social determinants of health,
Okay.
and then RTW, return to work.
Oh,
We're
I'm
an
not
industry
familiar
full
with-
of acronyms.
Yeah, our industry is acronyms.
I think what the fallacy in the VA system is everything is done by percentages, everything is administrative in determination. And so you're now making clinically determinative assessments through the lens of an administrative provision. That's not always the best way to do it. And one of my jobs is to reconcile those inconsistencies in the system so that there's a predictable aspect to how these compensation claims are evaluated. That's part of the problem. There was too much unpredictability in the system. So you could have two people with the same injury or affliction and end up with two different determinations. And I know we see that in Social Security. I'm not sure in workforce compensation if that's the case, but that's my job to help reconcile that inconsistency we see from case to case. And no, they aren't adopting best practices. It's a very slow to change system.
It's an interesting concept, given that military is an occupation and
Yeah.
workers' comp is occupationally related injuries and diseases. I would think there probably would be opportunity for some crosstalk, although you're talking about pretty different healthcare systems, delivery systems, logistical systems. The workers' comp system is complicated enough since it's pretty much a state by state. We wouldn't even call it a system because every state has their own. But certainly maybe on the medical level, would there be possibility for more crosstalk for identifying, things that maybe have been looked at extensively in the military population, and is there broader opportunity for that? And maybe it just simply hasn't been studied, but but the VA system has established, at least to their satisfaction, that something is an effective treatment, that they're willing to cover it, offer it. So those opportunities may be out there, and it may be something worth considering.
And I'll add one quick point. We just found out that the VA secretary is actually privatizing the compensation and pension system, the examination system. So you're going to have more doctors like Dr. Fisher and others who are going to be hired on if they opt to do that, to do these examinations. And so I hope in that way you start to see this osmosis of best practices as more people from outside, maybe that are doing things well, can also bring some of that into the VA and vice versa.
And if I can just jump in, this is an excellent crossover to a session coming next week about chronic pain coaching. Mr. Gillums, I hope you can join us next week, and Dr. Fisher as well, and Eddie. I was chatting with Eddie while you guys were talking. Next week's session is talking about how chronic pain coaching can help people with chronic pain. And I happen to know that the Veterans Administration is actively pursuing and embracing the idea of chronic pain coaching. And our speakers next week have been working with some vets and the Veterans Administration on that point. So super exciting crossover between this session and next week's session. So really cool.
Excellent.
And one quick thing is, Sherman, it's Karen Siebert. She said, tell us about your HEAL program and donating.
Okay, so AMVETS has a program that I started back in 2018. The idea was to fill the gap between those who provide the crisis intervention and the veterans who are not in crisis yet, but at risk of getting there. And so by the time we get them, we're looking at them as a whole person, and we look at things like finance, family issues, pain, physical pain, their experience, their journey, and we work with them and the VA and society to build a customized intervention approach to helping that veteran and that veteran's family not fall into crisis. And we celebrated 650 interventions with no suicides. We did have one death due to an overdose, unfortunately, and that's the reality. We're not going to save everybody, but we were real happy with being able to say that there is a way we can stop suicide if we individualize the treatment to an extent and pay attention to things that we often overlook. Regardless of how you feel about President Trump, he did acknowledge our program and publicly talked about how great it was that these types of programs were out there. So we were happy to have that at our last convention. And if folks want to donate, I think we're going to provide a link. You can go on anvets.org/vet-heal to look to read more about the HEAL program. There's also a button that talks about how to give. So if you click on that, make sure in the drop down you hit HEAL program so that the funds come to our program. It doesn't pay my salary. It doesn't pay the lights. We pay for suicide intervention training for police officers who are veterans and a host of other things that, in fact, warrior coaching is another service we recently were able to add to our advocacy because of H-Wave. They helped us fund 20 veterans to go through warrior coaching. So I appreciate what H-Wave has done quietly. They don't ring their bell too much, but they've quietly done the work of becoming involved and helping us actually bring solutions to what's been a longstanding problem.
Awesome. Well, thank you so much for the whole panel. Thank you, Eddie, Dr. Fisher, Mr. Gillums. I appreciate it. And you being here, being a part of Comp Laude. We'll continue to share this message. It was recorded, so we'll continue to share with the attendees that couldn't be here today. So for the audience, it is recorded. So again, thank you so much for being here. That was our last question. But contact information, should we just direct them to you, Eddie, if questions come in for today's panel?
Sure.
Okay.
Yes, please.
So Eddie's email is Eddie, EDDY, @altaclaimsservices.com. So you can contact, as well as on 2020virtual.complaude.com. All of their information, because speakers are there, is listed as well. So thank you so much, panel, and Yvonne and I will close out the session today.